Good evening, everyone. I'm Dr. Sullivan, and I'm back with you for another live Facebook mini lecture. Tonight, we're going to be talking about essential tremor. This is another movement disorder, and I thought we should focus on this topic this week because we actually had a lot of people, or most people ever, watch and listen to our non-motor symptom in Parkinson's disease lecture that we had last week. So there are, of course, some important differences between essential tremor and Parkinson's disease, and in fact, they often get confused, and I'm going to tell you tonight about some of the important distinctions between the two. But what I really wanted to do was to reach out to a new population of people out there on the internet who maybe aren't aware of neuropsychology, aren't maybe as aware as they could be about how brain health specialists like myself could maybe help them. Because so often people with brain health issues have neurologists, but many people don't have a neuropsychologist. So my personal slant that I'm trying to come to you every Wednesday night at 6 with is about the neuropsychological perspective. And so what this means is caring about things that you often can't see in neurological issues like cognition and mood. Those are the two areas that we focus on quite a bit as neuropsychologists. So some of you may know a little bit about essential tremor, some of you may have it, some of you may know someone that you care about quite a bit that has it. So what I try to do is kind of reach everyone and talk a little bit in the beginning about some basic education and then get into some more specifics that aren't often talked about within that specific brain health disorder. So why don't we get started? All right, so speaking about essential tremor, one of the things that is most surprising to me is how heterogeneous it is. And what I mean by that is that there's actually a lot of different types of symptoms that happen in essential tremor. And what experts actually think is that there's probably many different subtypes that exist within the overall umbrella term of essential tremor. And we see this in how different people's symptoms are. This is not a movement disorder that is the same throughout any given day. And in fact, there's a lot of things that influence the amplitude of the tremor, the disability level of the tremor, and we're going to get into some of that stuff later. But what we know is that this is a resting tremor. This is something that really affects people in their everyday lives when they're doing things like going to drink a glass, when they're going to tie their shoes. This is in contrast to Parkinson's disease, when you can typically have people that as they go to reach something, their tremor actually gets a little bit better. About 90 to 95% of people who have essential tremor actually have the tremor in their arms and in their hands, but it can definitely also affect the head in about maybe 30% of people. You could also occasionally get the tremor in the voice. We think that's about 20% of the folks, and about maybe 10 to 15% of people have it in their legs. The trunk is very infrequently affected, with what we think is about maybe 5% of people having the tremor there. The tremor is often what we call either a yes-yes tremor, up and down like this, or a no-no tremor, side to side. If you ever get your medical records, you might see your tremor talked about in that way, and I think it's a fairly obvious definition, but it is just sometimes handy to know how to decode those medical records. It's absolutely aggravated by things like stress, fatigue, caffeine, temperature extremes, and alcohol. And this is really unlike any of the other movement disorders, which, although there is some fluctuation throughout the day, essential tremor really seems to be something that's hard to predict for people who have it, how they're going to be feeling and behaving in any given moment, which certainly makes it more of a challenge to live with every day. We think that about 1 to 22% of older adults actually have some kind of tremor. And it's so often misinterpreted as Parkinson's disease because so many people in the public think of Parkinson's when they think of tremor. So many of these folks are walking around either getting misunderstood as having Parkinson's or being misunderstood as being anxious or even maybe being intoxicated, which can really be embarrassing for people. We know that with essential tremor, there are long periods of time where people's symptoms can be relatively stable, but unfortunately the tremors do spread to other parts of the body over time, and they do get more severe over time. The research tells us that the older you are when you start to get your essential tremors, the more likely you are to have a spread of the symptoms and a severity of the symptoms sooner. So the younger you are, you do tend to have longer periods of stability. But what really stands out to me about where we're at with essential tremor right now is, even though we know a lot more than we ever have, we actually don't have a lot of answers. The real, what we call pathophysiology of essential tremor is actually not known. We know what it's not. We know that it's not a dopamine problem like we see in Parkinson's disease. And if you read most scientific journals, we talk about it as being a structural problem in the brain, but it's really hard to uncover that and figure out what does that actually even mean. So what I thought would be helpful tonight is to maybe talk about some of the most recent theories about what parts of the brain are involved, because we've had really good advances in that in the last few years. And in fact, the location of where we know essential tremors is coming from in the brain is critical to understanding the non-motor symptoms of essential tremor. And these are the ones that I'm very interested in as a neuropsychologist that I don't think a lot of people know about. And these are the subtle cognitive symptoms and changes in mood. So in a moment, we're going to get to that. But I wanted to wrap up this part by talking about those differences between the two movement disorders of essential tremor and Parkinson's. The first thing that you want to think about is just base rates. So essential tremor is actually about 8 times more common than Parkinson's disease. And the age of onset is actually much more variable. So people can have essential tremor even dating back to childhood. And most people who get Parkinson's get it after about the age of 60. Now, of course, there is young onset, also, Parkinson's disease. And that's maybe in about 10 to 12% of people who have PD, and that is before the age of 60. But typically what we see in essential tremor is the age of onset is actually all over the place. People can have it as early as 10. People can have it in their 20s, in their 30s, and their 40s. What we know is that essential tremor always has a tremor, right? That kind of makes sense. Parkinson's disease doesn't always necessarily have a tremor. There's a lot of other symptoms in PD that you just don't see in essential tremor. And the two that come to my mind are the rigidity that you can sometimes see in people's muscles, and something that we call bradykinesia, which is basically a general slowing down of the person's body. That's not really what you see at all in essential tremor. What we also know is that Parkinson's tends to start on one side of the body, so it's unilateral, whereas in essential tremor, what we often see is that it is bilateral, and that people seem to have the most difficulty when they're holding an object that's kind of against gravity. So imagine someone like holding their fork and going to eat, or holding that cup trying to lift it up to their mouth. That's when the essential tremor really seems to kind of have its biggest effect. We also know that there are some commonalities between the two. So we know that they're both Parkinson's and essential tremor are affected by stress, are affected by anxiety, by emotions. But what we think is that essential tremor is probably even more so. We also know that alcohol seems to help people with essential tremor in the short term, whereas it doesn't seem to have an impact on the type of tremor that we see in Parkinson's disease. One other commonality is that there's actually no definitive, readily accessible test to be sure if what we're dealing with is Parkinson's or essential tremor. Of course, this is where clinical skill comes in, and working with a movement disorder specialist or a neuropsychologist that has seen a lot of patients with movement disorder. But there's no blood test, there's no common neuroimaging test that you can get. An MRI isn't really going to help us with that. There is something I'm going to talk to you about later, which is something we call functional neuroimaging, which can actually help us look inside the brain and see how it's operating, specifically how the chemicals in the brain are moving throughout with a focus on dopamine. Because remember, like I said before, essential tremor actually doesn't have much to do with dopamine, whereas Parkinson's disease, that's really the essence of the whole problem. One kind of quick and dirty thing that you can do, just roughly to separate essential tremor from Parkinson's disease is what we call the handwriting test. People who have Parkinson's disease tend to have a lot of things getting smaller and smaller over time. We talked about this in our last lecture, that handwriting gets smaller, for example. But what you see in essential tremor is handwriting actually tends to get bigger and a little bit more shaky. So if you just have somebody draw a clock, for example, or write you a sentence, stereotypically speaking, the person with PD is going to give you something that's really kind of small, a little bit hard to read. The person with essential tremor tends to give you something that's a little bit, also maybe hard to read, but just generally kind of bigger. And again, that has to do with the part of the brain that we know is affected. And we'll get to that in a few minutes. Now, of course, accurate diagnosis is everything when it comes to brain health. And I hope that if there's one thing you've learned from these lectures, if you've been tuning in, is exactly that it's so important to know what we're dealing with before we can really start to personalize treatment and care. Otherwise, we're just kind of throwing ideas at the wall and hoping that we're going to find something that sticks. This is what neuropsychologists love to do. We are detectives of the brain. We really thrive in complexity and trying to figure out all of the different factors that are creating someone's symptoms, and we understand the level of the problem and we try to come up with treatments that target each of the levels. Someone who has Parkinson's disease or has essential tremor very often has a lot of other things that are going on. We can't just simplify it and associate everything that goes on with them with this brain health condition. Many times people have diabetes that could be better controlled that's contributing. Maybe they see on some level, the alcohol does help a little bit, but in the long term, it's actually not good for other parts of your body. And in fact, with essential tremor, what some of the scientists think is that it actually makes tremor worse over time. It's almost like it helps in the short term, but really when you look at people's tremor in the long term, the people that become dependent on alcohol actually seem to slide down a little bit quicker than the people who don't get reliant upon the alcohol. Of course, knowing what you have is important for your education, for your empowerment, for people to be able to support you in the best possible way that they can. So I know a lot of people out there struggle so much with getting a correct diagnosis, but I really want to encourage you, or for someone that you care about, keep going, keep advocating for yourself to see the very best doctor, the best specialist that you possibly can. And of course, I'm always going to try to give you a plug for neuropsychologists because we really, really care as a group. We're very passionate about the brain and we really like to figure things out. So let's get to what is actually happening at the level of the brain. There are two basic types of essential tremors, how we think about it. The first one is something called familial tremor, which you may have heard of, and the other one is basically sporadic. The first one just simply means that there's a known genetic mutation. We do think essential tremors generally get passed down into families. If you have a parent who has the gene mutation for essential tremor, you have a 50% likelihood of inheriting that gene yourself. But of course, there's also people who develop it during their lifetime who have no known family history whatsoever, and that's thought to be sporadic. So as everything we talk about in this lecture series, there's probably a contribution from both genes and environment, and really where we're trying to focus so hard as scientists is figuring out what is that unfortunate combination of the two that makes these genes turn on for people to then get the disorder. So where in the brain is this all happening? This is actually pretty recent news within the last few decades. Brain health scientists have really figured this out. So when I think back to some of my early training, we used to think about essential tremor as actually being similar to Parkinson's in terms of where in the brain it was happening. And we thought a lot about an area called the subcortical area, which, you often think of the cortex when you think of the brain, but inside the cortex is the subcortex, where there's a lot of brain structures and really kind of the motor of the brain is in there. It's what helps us learn things. It's what helps us find our information. That's the emotional center of the brain, the memory center of the brain. There's just so much that happens in there. But what scientists started to figure out in the late 1990s and early 2000s is that essential tremor is located in the cerebellum and its connections to other parts of the brain, particularly the brainstem and the frontal lobes. And why this is so important is because we know what the cerebellum does, and it's not as it's stereotyped. Many of us who dabble in the brain, even if you're someone who's interested in it and likes to read popular science books on it, most people think of the cerebellum as being the coordination center of the brain. That's where we do our balance. And if you have a stroke or you've had an injury to the cerebellum, people do get a certain kind of a tremor. They might be prone to having falls. They might have difficulty raising a fork up to their mouth and start to get a tremor as it gets closer. But what a group of brain scientists in Boston at Mass General Hospital helped us understand is that the cerebellum is so much more than that, that there are reciprocal connections going into the brainstem, into the frontal lobes, into the parietal lobes, and this is where we get these mild cognitive and mood symptoms in essential tremor. So the way the brain works is it's very, very interconnected, and we used to think a certain brain area did only a very certain specific function, but of course we now know that everything is interconnected and so many things. It's a modulation system between getting focused on something and getting unfocused. So kind of like an excitation in your cells and an inhibition in your cells. And that's a big part of what the cerebellum does. It's really a gating system. So how it helps us cognitively with these reciprocal functions, the reciprocal connections, in the frontal lobe, is it helps us with things like our retrieval and multitasking and shifting set, knowing that we're focused here, but we're going to focus over here and go back and forth. We also know that the cerebellum is in charge of modulating our mood to a large degree. So sometimes people who have injury in the cerebellum will have very, very strong emotions, but they go away as quickly as they came. Sometimes patients will say to me, it's like a freight train. All of a sudden I get this big rush of a feeling, and it can be a positive feeling or a negative feeling, but it also goes away as quickly as it came. That is related to cerebellar damage. And when you start to look at the profile of these mild cognitive symptoms in essential tremor, that's exactly what we're seeing. So one of the things I like so much about doing these talks is I'm hoping that we can educate and raise awareness about these different brain health disorders so that people living with them don't feel so misunderstood. I think a lot of people who care about someone who has essential tremor will know, okay, I know that they shake. I know that they sometimes have a hard time putting the key in the hole. But there's these other non-motor symptoms that are so important to talk about because other people can't see them, but yet they're really, really affecting people's lives. So it's really a privilege for me to try to spread the word about these non-motor symptoms because I just think it's critical for people to truly feel validated with their disorder, with their brain health challenge, and to figure out how we can best support people. So when we think about essential tremor, we know that there are mild and many cognitive symptoms. That's kind of how we think about it, mild and many. And what I'm going to do right now is tell you a little bit about them. We used to think there were no cognitive symptoms in essential tremor, and actually I was talking with one of my colleagues here earlier today about me doing this talk, and we were both saying that when we were even being trained, I mean this is 10 years ago, we basically used to think essential tremor had no cognitive effects, but since deep brain stimulation has been invented and not only being used for patients with Parkinson's, but also essential tremor, they actually started to do a lot of research. The very first doctor who did it was Alex Troster at the University of North Carolina in Chapel Hill in about 1999. And he did a lot of research on folks that were coming in for DBS with essential tremor. And so he was able to get pre and post data from a cognitive perspective. And this was really the first big data set that was done, that was analyzed. And what it showed was that everyone who was tested basically had at least very mild cognitive symptoms. And they essentially happen within the realm of complex attention and set shifting and retrieval and verbal learning and memory. Okay, so if you or you know someone who has essential tremor, what the research would suggest, now of course everyone's different, but on the whole, there are at least very mild challenges within those domains. Okay, what we also know is that there's many parts of the brain and cognition that are not affected at all by essential tremor. So people's reasoning, their ability to do calculations, their ability to think abstractly, these things are not affected at all, it does not seem, by essential tremor. But we know that folks who have this have a difficult time sustaining their attention, being able to call up information quickly that is known to them in their brain, and to multitask, to go back and forth. And when you think about the cerebellum and what it does, this makes a lot of sense. What we know is that people with later onset of essential tremor, particularly after the age of 65, are at greater risk for developing dementia. Now, it's not necessarily a given, just like it's not in Parkinson's disease, but if you do have essential tremor, you are at a higher risk for going on to develop dementia. We also know that there are symptoms of depression, which I'm going to talk about more in a minute, difficulty with smell, difficulty with hearing. We know that hand-eye coordination and eye movement coordination can be a little bit difficult. And when I talk to my patients who have essential tremor, a lot of them tell me that they're very overwhelmed visually by different things that come at them quickly, like a fast commercial, or if they're driving in the car and they get above a certain mile per hour, it just feels like it's too much for their brain to take in. And probably this is related to the difficulty with eye tracking, that it's a lot. We don't realize when we have healthy, well-functioning brains how much this amazing thing is doing in our mind, and how much it's processing, and how much it's inhibiting, and how skilled we are at not paying attention to things. Never mind the paying attention, we actually do miraculous things every day with not paying attention to all these things that are coming at us in our vision and in our hearing and cognitively and interpersonally. We're really bombarded, and one of the brain's main function is to put the brakes on and say, look, it's enough, I gotta block some of this out. But when you have these difficulties with the frontal lobes, whether it's from direct damage or whether it's from what we would consider a problem with a reciprocal area like the cerebellum, that gating, that difficulty with modulation is really significant, and it's something that you can't see, but people who have this kind of a brain will tell you, if you listen, that this is just very difficult for me to take in a lot of information at one time. So let's talk a little bit about depression and essential tremor, because I would love to know what you all think about this. So about 30% of folks who have essential tremor have at least mild depressive symptoms. And for a long time, it was thought that this was due to living with a chronic movement disorder, and particularly one that was progressive, that was getting worse. And so people kind of just chalked it up to, a tough life, difficulty with everyday functioning, trouble with coping. But thank goodness we're making advances in brain research, where we of course realize that mood is just as brain-based as anything else that we do. It's just like using our hands takes our brain, so does our mood, and that depression for many, many people is extremely biological. What you see in Parkinson's disease actually is, and we talked about this last time if you were tuned into that lecture, is a lot of times people have depression symptoms, and I say that in quotes purposefully, early on, and then later on it goes to develop into Parkinson's, meeting criteria for Parkinson's. And so we see the same thing with essential tremor, that looking back, some people can say, I now know, knowing what this turned into, that my very first symptom was actually that I stopped being as interested, as motivated in things. And that's what our frontal lobes are doing. We would love to think that that's us and it's our drive and it's our initiative, but that's your brain, and your brain has to be healthy in order to do those things. So we now know that depression and essential tremor, just like in Parkinson's disease, is almost certainly from two sides. That the person, of course, is at risk because life is harder and people don't understand, but we're also at risk because of neurochemical and neurobiological changes that are happening in our frontal lobes. There are no medical tests, like I was saying before, to diagnose essential tremor. Sometimes if people have a really hard time with the diagnostics and they go to see many specialists and they still can't figure it out, they will do something called a Spect Scan, where you can actually look at dopamine uptake in the brain, and you can give someone a radioactive tag, doesn't that sound fun, in a shot in their arm, and basically you can look at the brain and see if it's using the dopamine in a normal pattern and in a normal way. And if you had Parkinson's, it would come up abnormal, but if it was essential tremor, you would of course see that the person was able to use dopamine efficiently. So thinking of the cognitive symptoms, if this is something that you or someone that you know has, of course you want to know what to do about it. So one of the things that I did a little bit of research on last night to just make sure that I understand exactly where the field is to look to see if any clinical trials had been done using any of the memory enhancing medications. And unfortunately, none have. If you know the way these memory enhancing medications work, it might make sense to think that we could have some promise there. And I'm sure many of you take it or have been put on these medications like Aricept or Donepezil, Namenda, Memantine by your doctors just kind of to see what happens. And at this point, because there's no FDA cognitive medications, of course, that's what we're left with. But what we do know is there have been some animal studies that have specifically looked at memantine in particular. And what we know is it does seem to have a neuroprotective effect on the cerebellum in particular. Unfortunately, in a small set of human patients, what they found was at the higher dosages that people actually, so this is maybe going above 30, like 30 to 40 milligrams, that unfortunately it caused an increased tremor in these folks and a lot of fatigue and sleepiness during the day. So, you know, what can you take from that? Well, maybe the lower doses might be helpful, and you should certainly talk with your doctor about that, but unfortunately there aren't really any medications on the market nowadays that specifically help the cognitive effects. Of course, many people who have essential tremor take medications once the tremors get to the point where they're affecting quality of life or activities of daily living. And there's really 4 classes of medications that most people take. So the first one is beta blockers, and you might think of these as medications that typically treat things like high blood pressure, but we do know that they can also calm down tremor. They're anti-seizure medications such as primidone, sometimes different types of what we consider to be pain medications like Neurontin or even Topamax are used. Tranquilizers like Xanax and Klonopin are also used particularly for people who find that anxiety or tension makes their tremor a little bit worse. And sometimes people also use Botox injections, particularly if they have a head or a voice tremor. Botox typically helps people for up to about 3 months. Of course, deep brain stimulation is something we have to touch on if we're going to talk about treatments. This is being used more and more. In my practice, me and my colleagues see a lot of folks from the UNC program actually for both Parkinson's and essential tremor prior to their surgery to make sure that they are indeed good surgical candidates. What we know is that DBS for essential tremor absolutely helps the tremors, but what we didn't know, and up until recently, and I would say it's actually still a little bit of an ongoing question, is what do we know happens to some of these non-motor symptoms, cognition, mood, quality of life after people undergo DBS. So in general, it's thought to be favorable. I think it's all interconnected, of course. So if your tremor gets better, your mood's probably going to get better, your quality of life's going to get better, which of course in turn helps your attention and your memory and your ability to focus on things. We know that DBS has been associated with a significant reduction in anxiety, and as a psychologist, I would assume that part of that is related to a greater sense of control, predictability, knowing exactly what you can expect. The only area that's been shown to possibly go down in some people is something called verbal fluency, which is just simply the ability to quickly recall information. And we've seen that that's not an essential tremor thing. We also see that in Parkinson's disease too. Of course, there's other types of therapies that are really helpful. So physical therapy, occupational therapy, all these things can help with muscle strength, with control, with coordination. Occupational therapists are amazing professionals who can help you in really an everyday setting. I was interested in going into OT when I was a lot younger because I love the practicality of it and really getting into people's homes and trying to help them on a very individual everyday level. So they're the folks that help you figure out, okay, are there weighted utensils that you might want to use that can help you a little bit more? Are there wide grip pencils that would maybe help you? They really help with the activities of daily living things. And of course, exercise. We'll say it time and time again in our lecture series. It's kind of the cure-all. I wish it was a complete cure, but it's definitely the most evidence-based recommendation that we give people with brain health conditions. It really just helps so many different things. There's direct benefits in terms of helping nerve cells regenerate, and there's indirect benefits, which of course help your sleep, your socialization, if you exercise with a group of people, your mood, so many benefits. Then, of course, I have to tell you all about neuropsychology, right? We are clinical psychologists who have an additional 3 years at least of training in the brain. We are not physicians. Unless we live in Louisiana or New Mexico and have taken a few more years of school, we do not prescribe medications. But I think that we're a pretty awesome group of professionals. I think that we're very curious and we genuinely really care about our patients. We see a lot of people after they've been searching for answers for a really long time, and we really truly enjoy figuring things out and coming up with a personalized plan to help people. So in conclusion, the things that feel most important to me is that we've learned that essential tremor is not just one kind of brain health disorder. It's got a lot of different subtypes. People have very individual types of symptom profiles. We know that the cerebellum, the part of the brain that, yes, while it is involved with coordination and balance, also has a lot of an effect on our cognition, our ability to multitask, our ability to retrieve, and our ability to modulate our mood. We also know that it is absolutely critical to get an accurate diagnosis, and if that's something that you're still struggling with, I would really encourage you to advocate to have a neuropsychologist. And in fact, I'll take that a step further. I think if you're out there and you or someone you know has essential tremor, you deserve a neuropsychologist as part of your care team, because as good as neurologists are, and believe me, I know some of the absolute best, the truth is that we are psychologists. We are just going to approach this condition from a different perspective, and I think that you need someone on your care team that cares about the feelings part, the adjustment part, the cognitive part. So to me, a perfect care team is a movement disorders neurologist, specialist, and a neuropsychologist who enjoy working together to give you the very best care. Thank you guys so much for listening. I wanted to sign off by telling you what we're going to talk about next time, which is mixed dementia. And this was inspired by a wonderful new support group online that I'm trying to become a part of slowly. And so many people on there have been diagnosed with mixed dementia. So what that means is someone doesn't have just one brain disease that's causing dementia. Someone can have Alzheimer's disease and vascular dementia. Someone can have vascular dementia and Parkinson's disease dementia. So I'm going to just talk a little bit next week about what happens when multiple types of dementia come together, how we try to tease those things apart as neuropsychologists, and how is it that we can best support people who are living with those challenges. Thanks again so much. Please help me spread the word. If you know anyone who has essential tremor, I would really appreciate you letting them know. What we talked about tonight is very important to me to help empower people with information. That is why we are here. Thank you guys so much, and I'll see you next time. Bye-bye.